Thank you very much for joining us today for our conversation with Dr. Talya Greene, head of the Community Mental Health Department and associate professor at University of Haifa. I'm Lisa Silverman, CEO of the American Society of University of Haifa. As we continue to grapple with the unpredictability and fatigue that are the byproducts of this pandemic, we search for better understanding and insights into our own mental health and well-being, and that of those who are on the front lines caring for us and for our community. As an expert in mental health consequences of mass trauma events, Dr. Greene will discuss why COVID and mental health are so interlinked, especially for frontline workers, and will share her recommendations for all of us for coping strategies. We invite you to submit questions for the Q&A anytime throughout the conversation through the icon at the bottom of your screen. Noah Amuel, thank you for moderating our session today.
Thank you very much, Lisa, for that lovely introduction. And Talya, thank you so much for joining us today. I'd like to start off by asking you about your work. You conducted a study saying 58% of frontline workers met the threshold for a mental health disorder, and 22% met criteria for post-traumatic stress disorder, otherwise known as PTSD. 47% had clinically significant anxiety, and another 47% had depression. So what needs to be done in order to ensure that the mental health needs of frontline workers are properly addressed?
Thanks, Noah, and thanks, Lisa, and everybody for having me today. Maybe I'll start by giving a bit of an explanation about that study, and it helps to put it into context and to understand, what all of those numbers mean. I think the first thing that's important to say is that this is a study that was conducted in the UK among frontline healthcare workers, not just doctors and nurses, but across the health and social care sector. So also people working in nursing and care homes, cleaners, porters, administrators, healthcare assistants, allied healthcare professionals. So a really broad range of healthcare professionals were involved in the study. And we did the study right after the first wave that COVID had hit. So we're talking about May, June, July, that kind of time in 2020. So at that time, we didn't know it was only the first wave. We just thought it had been the wave. And people, I think, were still reeling from a very difficult and stressful time. Working conditions have been very, very hard. There hadn't been proper access to personal protective equipment, to PPE. And there'd been really very high numbers of COVID cases in hospitals. And the healthcare system maybe wasn't totally overwhelmed, but it came really close to it. And so I think this comes in a context of that kind of shock and difficulty. And so I'm not that surprised that numbers were that high in that context, but they really were high. So overall 58% met criteria for at least one of those three disorders. And some of them met criteria for all three. So when we say 47% had depression, many of those 47% also had either PTSD or anxiety. It was really a hard time, and we examined not only their distress, but some of the factors that were just driving some of the distress. And some of the things that we found were things like not being able to talk to their managers, feeling stigmatized because of their healthcare role, being really worried about infecting others. That was something that was really a risk factor for distress, feeling like they couldn't talk to their managers and leaders. And one of the really key things that we found were not having had access to proper protective equipment was one of the key things that put people at risk of a mental disorder. And so I think it's really clear that the first thing we need to do is make sure that people feel protected, that they can talk to their managers, that they're in a supportive environment. And the other thing that we found was about access to psychosocial support. So obviously, if people are very distressed, we want to make sure that they can get therapy if they need it, that they can have a conversation with a mental health professional. And in a lot of cases, there was psychosocial support theoretically made available. But in a lot of those cases, it was only theoretically made available. It was very hard to access. It was full up. It was during working hours, and people were maybe agency staff. They weren't full-time employees, so they couldn't access the care. So I think it's also about making sure that people feel looked after, not just protected physically, but also there's kind of a safety net for them, and that they know that if they have some kind of difficulty, they can turn somewhere for help and that they will receive it.
Well, this is a follow-up question to that. A good amount of time has passed since that study. Do you know if management in the healthcare industry has gotten that memo that healthcare workers need not only the tools like PPE to do their job, but also someone to talk to when things are very difficult? Do you think they understand that?
I think it's really variable. I think it very much depends, not even on country or even institutional organization. Sometimes it's really about, is the manager good at this kind of conversation? Is it a supportive environment? Is there a sense that it's okay to say that you're not okay? Is it all right to ask for some time off? And I think that varies massively from place to place and person to person. I think that what we are seeing now is a lot of fatigue and exhaustion, and people are burnt out. And that's true also for managers and leaders and, you know, people running organizations. And so I think it really filters down the sense of, I'm so tired and I don't know if I can keep going. And so in some places, people understand that what they need to do is create this supportive atmosphere where if people need help, they can ask for it, and it's considered okay to say, I'm having a tough time. But there are lots of places where the attitude has really been kind of just suck it up and get on with it. And, you know, we're all in this, so why are you making a fuss? And so it's really mixed. It's really, really mixed.
Yeah. Well, so what would you say would happen? Like the worst case scenario, if mental health workers don't get the support they need? You talked in that study about you're seeing a mental health crisis across the healthcare and social sector. So if that crisis goes unchecked, what does that reality look like for the healthcare industry?
I think there's two kind of things that I would worry about. The first is that people that are still doing their jobs feel really unappreciated, not looked after, and they lose motivation for their work. They're doing it half-heartedly. They're not doing it with the love that they once did. And I think that filters down to the patient experience. So I think that the first concern is that people are doing the work that they did because they really felt kind of called to and drawn to this meaningful work. But in practice, they've lost that passion and motivation for it. And so patients get, you know, they don't get the same experience that they once had. And the other major concern, and probably the major concern, is that people will just leave these jobs, either because they feel that they can't go on or it doesn't seem worth it. You know, there's no amount of money can compensate, or even if they are compensated, it feels meaningless. And so I think that's my big concern, is that we'll see a kind of drain of healthcare workers who will just look for other jobs if this goes on in this way, where people continue to feel unsupported. I don't think it's a given, though. I think that there's a lot of quite simple things that can be done, like putting psychosocial support, you know, in place routinely, making sure that people can take the breaks that they need. I think showing support for carers is much more than just kind of clapping. In the UK, I was in the UK during the beginning of COVID. I was on sabbatical, which is where I did that work, and people were clapping for carers every Thursday night. And I think that is nice, but only to a point. And sending pizzas to, you know, emergency rooms is nice, but only to a point. I think that we need real kind of serious systemic change where people are valued, do feel protected, do feel that they're seen as being worthwhile and giving a meaningful contribution. And that, I think, can go a long way to keeping people in the healthcare sector.
Absolutely. Retention is key. And before we move on to the next question, I did want to just remind the audience tuning in, if you're on Zoom with us, please look at the Q&A icon down below for if you want to submit a question. And if you're tuning in on Facebook, you can just write a question in the comments and we'll try to address it in the Q&A portion of the webinar today. And then Talya, I did want to talk to you also about workplace, the workplace ambiance. You hear so many words being tossed about, like stress, anxiety, burnout. What exactly do those three things actually mean? And how are they different from one another? How can you differentiate? How can you identify if you're experiencing one of those three, I don't want to say symptoms, phenomenons?
Yeah. So first of all, it's really important to recognize that these three things are very closely linked and often lead to each other or co-occur. But I'll try and kind of unpick what those different terms mean, and maybe that will help to explain. So I think stress is best understood as the reaction that someone has to pressures that they feel overwhelm them or exceed their ability to respond. So if you're dealing with just a hugely demanding workplace, for example, you know, too many patients, a very big caseload, a sense that you're understaffed, that might feel overwhelming and like you personally can't cope, and your organization or your unit or your department or ward can't cope. And it leads to this kind of feeling of being emotionally overwhelmed and feeling like you won't be able to cope. That is stress. Burnout is linked, but burnout is what you usually feel when this has been going on for a really long time. So it's cumulative. Usually you can even kind of sense that it's coming. It doesn't tend to come by surprise. Burnout doesn't come out of the blue. It comes after you've been really dealing for a long, prolonged time with more and more and more stress. And it leads to this feeling of fatigue, exhaustion, a sense of being drained, like I haven't got anything more left to give. And it's burnout often internal. So I feel burnt out. I just feel finished. But it's also can be transferred onto patient care. So you might feel I can't do it anymore. I can't look after anybody else. I don't have that in me anymore. I'm just exhausted. You can see burnout obviously in the healthcare sector. You can see burnout, you know, in any kind of work setting, and you can also see it personally. So you can be burnt out with your family duties, or, you know, friendship duties. It doesn't have to be just in the healthcare setting, but it's when it's been going on for a long time and it's cumulative. Anxiety is different. Anxiety is when you're thinking about something that you anticipate coming in the future, and you're worried about it, and you can start to maybe try and avoid situations to lead that, or you can get very distressed when you think about that stressful situation or the thing that makes you very fearful. So anxiety is really about anticipating something that will happen or might happen in the future, and the emotional and cognitive responses and behavioral responses that you have to thinking about that potential stressor.
And we've obviously heard all these words before COVID began, but what is it about COVID that makes stress, anxiety, burnout words that we're hearing all the time now?
I think, first of all, it's quite a common experience. I think that although my research has focused a lot on healthcare workers and other frontline workers, actually, I think we can all really identify with feelings of stress. I'm pretty sure everybody over the last 2 years has experienced some stress, whether it's trying to juggle family duties with work duties when everybody's at home on Zoom, or the fact that there's kind of no clear break between work and home, and that's quite stressful. I think burnout, again, I think a lot of people feel very burnt out from the pandemic, and trying to cope with all of the uncertainty for such a long time, I think has caused this feeling of burnout, and everyone's kind of had it. And anxiety, I think a lot of people are very worried. We're living with really uncertain times, and we don't really know, you know, maybe Omicron is kind of the beginning of the end of the pandemic, but maybe it's just another wave, and there'll be just another variant around the corner. And I think that this kind of anxiety about, we don't know what, you know, we don't even know what 2 months time will look like, or next week will look like, let alone next year and 2 years and 5 years. And so I think that we all kind of share this common experience of a bit of stress, a bit of burnout, and a bit of anxiety. And for some of us, we might be dealing with way more than just a little bit of that. And so I think that is why we're really hearing about it, because it's hit hard and it's hit us all. And so maybe people are more aware of kind of their emotional and cognitive responses to the situation maybe than they once were.
Not to be insensitive, but do you think perhaps this could be one small silver lining to COVID, that people are more emotionally intelligent about what people are feeling, and maybe a little bit more empathetic than they were before this pandemic?
I don't know is the answer. I think that for some people it has helped them, kind of, help is the wrong word, but they've kind of thought about their priorities again, and they know what's important for them, and maybe they do value, you know, the people that they're spending time with, the people that they love, or they looking for, you know, work-life balance, or, you know, I think there's been a lot of reassessment going on, and maybe that is good for some people. I think for a lot of people though, that when they're distressed, they're just distressed, and they're kind of you know, they didn't necessarily need to feel distressed to recognize that other people also feel distressed, but it's just where they're at right now. So, you know, I don't know, again, I think it's very mixed and very personal, and some people might look back on this time and say, this was a very important time in my life and really helped me to think about what I want to do and where I want to be moving forward. But I think there'll be lots of people who said, this was just such an awful time in my life, and it was just stressful and difficult, and you know, I wouldn't go back there again for the world. So
sure. Well, speaking of burnout and not going back, this pandemic started 2 years ago. We were told that we would need 2 weeks to flatten the curve. It's definitely been longer than 2 weeks. So what advice would you give for people who are just exhausted and they're sick and tired of the rules and regulations that come with navigating this pandemic? And how do you think their symptoms of stress differed from back then 2 years ago to now?
I think at the beginning, we kind of, all of us switched into this emergency mode. And emergency mode, you're running on adrenaline and you think, you know, I can just do this and it will all go away. If I just follow the rules, everything will be fine. And I think that, you know, and at the beginning we said to people, you know, it's a marathon, not a sprint, because, you know, it kind of felt like a thing that needed to be said. And I think now, 2 years on, everybody knows it was a marathon, not a sprint. And it was some kind of, you know, ultra endurance marathon that nobody even could have even imagined, I think. And I think we're not running on adrenaline anymore, and you can't do that. I think that what we see now is, because we've got these, you know, very serious, very deep running exhaustion and fatigue and burnout and stress and anxiety and all of the things that I mentioned, we really need to focus on taking care of ourselves and taking care of each other. So I think on the self-care level, what does that mean? That means things like still maintaining routine and trying to cope in a healthy way, not an unhealthy way. By that I mean, you know, eating healthily, sleeping, you know, when you should do, not using unhealthy coping strategies, for example, using, you know, alcohol and substances to cope, not eating in unhealthy ways in order to cope, you know, cope emotionally. It doesn't really help in the long run. Spending time with people that you love, doing things that you enjoy, you know, making time for those things that kind of balance out the negative. So thinking about things that help you to calm down, thinking about things that you enjoy doing, and sharing how you're coping with the people around you. I think that there's also a kind of community level coping. And I think that feeling part of a community is really very helpful. We know that there's this term community efficacy, which means, you know, your belief in the community to cope, and community resilience and social resilience. And I think that really feeling that we are all in it together and we look out for each other. And when people are having a tough time, if they've caught COVID and they're feeling ill, then you look after them and you go around and take some food. And actually we know that helping other people is kind of empowering and a good way to actually cope within yourself. So I think all of these things can help us to get through it.
For sure. And let's talk about people who actually got COVID, got physically sick. There's this phenomenon called COVID long haulers, people who've experienced COVID symptoms long after they've recovered from COVID. So can you talk about what they're going through? Are they experiencing any long-term psychological trauma from having COVID?
So I think, again, with COVID, it's good to try and understand what their experience has been. I think there's no kind of one size fits all here. For some people who had COVID, particularly people who were seriously ill and were in hospital, I think it's very clear that that can be a trauma. We know from previous studies that something like 20 to 25% of people who are treated in an ICU, an intensive care unit, will develop PTSD afterwards. We know that also depression can be very high amongst people who've got chronic illnesses. And so I think if you've come close to death or perceived yourself as being close to death, we know that that is absolutely, potentially traumatic and for sure can drive PTSD. So I think for people in that who had that experience, particularly if they had that experience where they couldn't have family members come to visit, if they were heavily sedated, if they were ventilated, all of these things are genuinely very, very traumatic and very confusing as well, and often involve drugs that can, drug treatments that can cause hallucinations and delirium. all of which can drive PTSD. So I think that for that group, I really would expect somewhere between 20 to 30% of people who had COVID and were hospitalized and treated to actually go on to develop PTSD. I think for long COVID, one of the things we're seeing is that it was not necessarily driven by a serious illness at the beginning. So some people didn't have a serious COVID illness, but they've just dealt with these persisting symptoms for months and now even, you know, up to 2 years. And for that group, I think there's something different going on. There may well be some PTSD to do with their symptoms and their experience, but there may also be depression about what's happened with them and how their life has changed, and coping with the effects of this, you know, of this experience. And anxiety about what might be and whether they'll recover, and what does that look like. One of the things that's complicated with long COVID and mental health, or chronic illness and mental health, is that we see that they come together. So there's a close relationship between body and mind, and we see that there'll be, you know, people who've got chronic illnesses often have high rates of mental health problems. What we don't know is what drives what, kind of chicken and egg. So are these mental health problems partly driving their physical symptoms? Are their physical symptoms driving the mental health symptoms? Or is there some kind of dynamic that actually both of these are involved? And we need to have multidisciplinary teams. So we need to have both psychologists and you know, physical rehab and physiotherapy and occupational therapy and doctors all working together to try and support people who are having these kind of ongoing difficult COVID-related health problems.
Yeah, and it can be as minute as still not smelling like you used to, or still not tasting coffee the way coffee always used to taste, or just not being able to concentrate. I mean, I know people who've experienced all ends of the spectrum, so it's great that you're bringing awareness to that. I also wanted to ask you about the CDC. They've added people with mental illness to the list of people who should be prioritized for COVID vaccines and boosters if we end up having more boosters than what we already do have. So why do they make this decision, and why does mental health have to do with someone's status as being immunocompromised?
All right, so the answer to that is also a little bit complicated, and I'll try and kind of go stage by stage. The first thing, what do we know from research? We know that people that live with serious mental health problems are a vulnerable population. Even in non-COVID times, so nothing to do with COVID, you know, before 2019, people with serious mental health problems on average live shorter lives. They have lots of medical problems, they suffer, you know, more likely to suffer from chronic illness. And again, we don't know what drives what, but we do know that they're a vulnerable group. Specifically with COVID, we've seen from our research that patients with mental illness are much more likely to die of COVID than their peers. So if they catch COVID, they're more likely to have it worse. It will be more severe illness. It's more likely to lead to death, but possibly up to twice as likely. And so on a kind of very basic scientific level, the CDC recommended the vaccine be prioritized people with mental health problems because they could just see that there was definitely a raised risk. In terms of why, like I said, there's multiple reasons. And again, it's, you know, there's this interaction between body and mind, and it's not really body and mind. These things are kind of more one thing than we like to kind of categorize them. But we do know that people with mental illness are more likely to have heart disease, obesity, diabetes. Living with chronic stress can really inflict a toll on people's physical, you know, status. People are more likely to live in poverty if they've got mental health problems, more likely to live in institutions which have lots of people living together. So COVID is more likely to spread in those situations. There may also be some kind of physiological reasons that we're only starting to understand. There seems to be some kind of immune response disturbance in people who've got schizophrenia and bipolar disorder, so that bodies might not be as effective at fighting COVID. We don't know whether that's a kind of shared vulnerability or whether that's because the psychiatric medications raise the risk. We know that people don't access healthcare as quickly when they have serious mental health problems, perhaps because they've had difficult experiences with the healthcare system in the past. So, as I said, it's a really complex answer. And I think the short answer is it's a marginalized group who have worse health. They're more isolated often, you know, less of a social or support network. And I think that, you know, that makes them vulnerable.
Sure, that's very sad. And I wanted to pivot just a little bit to your specific research. Can you talk about what you're working on, what's next on the horizon? I assume it's going to be more related to COVID since this is an ongoing saga, unfortunately. So can you just share that with us, please?
Yeah, so so as Lisa said, my expertise has been in mass trauma, the consequences of mass trauma. So I've looked at that in lots of different groups, including soldiers, people exposed to rocket attacks in Israel, and most recently in healthcare workers, a little bit of religious leaders as well. And one of the things that I looked at was this thing called moral injury, which is a term that's kind of made its way from the military into the general kind of discourse. We've seen it in newspapers, maybe you've heard about it on, on the TV. What moral injury is the psychological distress that people can experience when they do something or see something that goes against their own moral code, their kind of fundamental sense of what's right and wrong. So in the military context, that might be soldiers being given orders to do things that they don't agree with, and that causes a lot of distress when they carry them out. And when COVID hit, there was a lot of talk around healthcare workers that this was going to be relevant because healthcare workers were going to have to ration equipment or medications. They were going to stop family members visiting, and they were going to do things that were at odds with their own sense of right and wrong, and that was going to cause distress. So I started this research back in the UK, where I looked at moral injury and stress and trauma and burnout in healthcare workers. But actually, now that I'm back in Israel, I was in the UK just for a year on sabbatical. When I came back to Israel, I decided to set up a similar study that we're actually about to launch in about a month, looking at healthcare workers and mental health professionals in Israel, a very large study looking at their experiences of moral injury and stress and burnout and trauma and depression and PTSD during COVID, and also kind of looking ahead. So it's going to be a study where I track them over 6 months every month. But I think if I think about other studies that I'd like to do, I think that this kind of template works very well also for other groups that are at risk of occupational trauma. So the kind of groups that I'd really love to extend this research to are, for example, the police, the prison service, teachers, firefighters. I think there's lots of groups that are not just COVID related, but in routine times get exposed to potentially to moral injury, certainly to trauma and to stress. And I think that with all of those groups, if there were serious cases of burnout, we need all of those groups to function properly. We must have a functioning police force and prison service, and teachers and firefighters, because the consequences of people leaving those jobs or not doing those jobs, wholeheartedly are really very serious. So that's the kind of next phase of the work. I want to basically take the template of the research and expand it into other occupational groups.
And I would imagine it's also very important work because I think the more people are not invested in what they're doing, they become prone to corruption, or as you said, leaving. And these are institutions that it's in our best interest to protect because they're ostensibly supposed to protect us, I would imagine.
Absolutely. And I think that what we're seeing in the work I've done so far, I've seen that one of the things that's really been driving this distress is, like I said, moral injury is kind of this doing something or witnessing something. But the third aspect of moral injury is actually betrayal experiences. So they feel betrayed by the people, the organizations, institutions that are supposed to look after them. And that is what we really saw very clearly in that first wave of COVID, that people talked about their betrayal experiences, saying things like, they offered us support, but they didn't really mean it. They just left us, they abandoned us. And it was chaotic, and there was no proper training, and everything was too little too late. And, I don't trust my leaders. I don't trust my boss anymore. They don't care about us. People used words like cannon fodder. They felt like they'd just kind of been thrown out into the kind of front line of the healthcare world to treat people, but nobody cared if they got sick or that, if it was hard for them. And so I think that we see that with healthcare workers during COVID, but we see that with healthcare workers also not during COVID. We certainly see it, the prison service. I think the people who work there are exposed to a huge amount of trauma. It's very, very difficult, hard working conditions. And I think that we're just seeing the tip of the iceberg. When we think about moral injury and trauma in those groups, we don't understand very much about it. Everybody knows it's there, but they don't really understand it. And they also don't really understand how best to treat it. What works for the military might not necessarily be the right approach for healthcare workers or for teachers, for example. They've not kind of signed their life away. They didn't sign up for this. That's another thing. People feel like in the military, you know that you take risks and you've signed up to take a risk. But healthcare workers didn't really sign up to take a risk. Teachers don't sign up to take a risk. They sign up to do something else. And so I think understanding the best way to support these different groups is really critical.
For sure. And then speaking more about your research, can you share with me any other anecdotes you've heard from people who've either experienced moral injury, you've talked about, or stress and anxiety due to COVID? If you could share with us any insights on a personal level, that would be very helpful for our audience, I think.
So we did research that was quantitative. So, we did surveys and we've translated it into numbers, numbers, and done stats with that. But I think actually one of the more interesting things is the qualitative research that we did, research where we had interviews or we asked people to write, about their experiences. And there we're really seeing, things like the juggling, that they were at work and it was awful, and they were having to do things like be the ones on the end of the iPad, holding up the iPad so that family members could say goodbye to their loved ones in the hospital. And they would be doing that, for 3 hours a day, and it was awful, and making, multiple phone calls, and it was extremely distressing. And then they would leave and they'd go to the supermarket on their way back, and people would see that they were dressed in their, their medical, like their scrubs or with their medical badge. And then people wouldn't want to stand near them because they were scared that they'd catch COVID. And then they'd get home and they'd be stripping off in the, in the garage to change their clothes, or sleeping in camper vans in the front, in the front garden, so they didn't have to bring COVID into the house. And then they'd hear about the stresses of their family members, who were also trying to juggle Zoom school and their partners were trying to work and parent. And just, I think that's what we're hearing, is this really overwhelming sense of blurred lines between work, between home, this kind of shared trauma of going through everything that all of society is going through, but there being no break. Even when they get home, the news is all about COVID. And I think that is that was the narrative of, really, we've had it very hard and nobody really cared. And, they clapped for us and everything. And, they kind of made all of the right, noises about caring about what we were doing, but they didn't really, and they didn't really try and protect us. So I think those are the kind of things that we're hearing. I think that what's important is to really, first of all, thank people who are doing this work, especially those that didn't sign up for it. I think remembering that it's not just the doctors and nurses, but actually the healthcare system requires, a huge number of different roles. And some of those roles are kind of seen as heroes, and some of those roles often get forgotten about, particularly people, I'm thinking about, for example, cleaners and porters, and, people who are kind of typically already receiving low wage, often living with quite insecure contracts. They were also right at the front line and dealing, being exposed to COVID every day and keeping the healthcare system running. And so I think, kind of thanking them, legitimizing the fact that they had a tough time and they're still having a tough time is important, and listening to them when they say it's hard. I think those are things we can do to support them.
Sure, for sure. And I'd like to just open the rest of the time we have left to audience questions. So I'd like to first start off by starting with a question from the audience talking about long-term effects of COVID and in terms of stress, specifically for young people who, if you're under 5, this is probably all and all you're remembering. So do you see maybe a generation from now, 2 generations from now? What do you project for this generation that unfortunately may very well be shaped by this era?
So I think it's important first of all, I think it's important not to panic, that, kids are quite adaptable. My youngest is 6 and she's kind of adapted, and, as you say, it's all they know. And so in a way, they're kind of, it's easiest for them. They've got nothing to compare it to, and this is their reality and they deal with it. I think it is harder for older children. So I think adolescents are having a really tough time. They're missing out on all kinds of formative experiences that we would want them to have, school proms and, and camps, got cancelled and things like that. That's really, those disappointments are very, very hard. Again, for the most part, I think that if you are being brought up in a stable, loving environment, then and with a community and a family around you, then most kids will will be okay. I'm worried about the ones that are living in unsafe situations, and that COVID has kind of exacerbated that. So, the ones that aren't going into school and now are living in violent environments, or with parents that are suffering serious problems and aren't able to give them the support that they need. People living in poverty. There was trying to do Zoom school if you're doing it off, your one mobile phone that the families share, versus families where everybody's got a laptop and the Wi-Fi has been upgraded, and they're just they've got all of the resources and support that they need. And I think that what we're going to see is that COVID has really exacerbated those gaps, and vulnerable people have become more vulnerable, and poor people have become poorer. And I'm worried for that group of the children and young people growing up in those environments, because I think that the repercussions for them will be serious and long term. And I think that we'll see, 20 years from now, we might still be seeing children who were really bright, had all the potential to do well, and this kind of derailed them, and their education was impacted, and that impacts on all their kind of future, the future trajectory. So it's kind of a mixed concern, but I think for many people, we don't need to be too worried, and they will be okay, and we just need to help them get through this really difficult time. But for others, it really is hard. And then obviously there's some kids who will develop serious mental health problems. We are seeing, and recent research is showing that rates of depression and anxiety amongst children have gone up, because it is an anxious time. And it's understandable, and all their kind of routine structures and supports were affected. And they're in school one day, and then they're home, and then teacher's sick, and their friends are sick, and it's worrying. So I think we need to do research to understand which people are vulnerable and what do they need. And I think understanding what they need is really that's the real puzzle here.
Right, absolutely. And at least I would like to think that the next generation, words like anxiety, stress, burnout, all that we've talked about through the whole session today, won't be as taboo as perhaps they are now, or they were in our parents' generation. I'd also like to ask about the future. How do we, to use a popular political phrase by President Biden, how do we build back better in terms of the mental health crisis? How do we protect ourselves from the next crisis, pandemic that could be on the horizon, hopefully a long, long time from now? But whatever will be around the corner, how can we make sure that we're ready for it, or try to be ready for it?
Listen, I think we can guarantee that there'll be something around the corner. I think, these are uncertain times, and we're living in an unstable global world. And I think, there will be a crisis, whether it's extreme weather conditions, climate change. In Israel, obviously, it's always, things can change very quickly, and the security situation can start to overwhelm. So, and for me, I think the things that are crucial are that in routine times, we have the support in place that people need, so people can access psychological support when they need it. At the moment, we know that waiting lists in Israel for mental health support are bigger than they've ever been. It's really, really, even private care is almost impossible to access immediately. And so I think we need to think about how to both have more people that can provide that support and create an atmosphere where people can access it, and systems where they can access it. And we also need to think about ways to scale up that support. So, maybe it's about training more people, so you don't just have, clinical psychologists and psychiatrists, but maybe, peer support providers, caseworkers, other people that can kind of provide that lower level or first level support. And maybe, things online, digital, psychiatry, self-care apps. All of these, I think, have potential, and we just need to work out how to test it, how to devise it so it, people use it, and how we can really support them in accessing support where needed.
Absolutely. And then I would like to close by one last question from our audience who talks about the radicalization from the public. You hear of anti-vaxxers, you hear of people who are even combative with healthcare professionals for wanting to treat people with COVID, for wanting to administer vaccines. How do you explain this vitriol that you're seeing in some fringe of the public, but that we are seeing, unfortunately? How do you explain it, and what can we do to make sure that our healthcare professionals are, at the very least, protected from these members of society?
So again, it's really complicated. Obviously, for healthcare workers, when we talk about things like betrayal and moral injury, I think that's been very difficult for them to deal with, because they feel like they have, given everything up in order to help people, and then now they're treating people who don't even want to be treated, or didn't believe in the thing that they've now got. That's hard. But I also think that one of the things that's important that we do as a society is not polarize even more. I think that, when people haven't got their vaccination, sometimes it's because they've, read all kinds of anti-vax stuff online, and it's led them to believe that there's something dangerous about it. Sometimes it comes from a place of anxiety. Sometimes it comes, there's a lot of mistrust. And I think that we need to understand how to respond to people with patience, with understanding, try and understand where these concerns and anxieties are coming from. And rather than kind of respond in a combative way, I think there's, can we talk with people? Can we explain? Can we show the science in a way that doesn't kind of talk over people, but really answers their questions? I think that being nervous about something medical is, that's understandable. Lots of people are nervous about medical procedures and medications and the healthcare environment. And so I think if we can really respond with kindness and with patience, then maybe that also, gets reciprocated. And I think anything that polarizes is dangerous. So we need to kind of try and find where the middle ground is. And obviously for healthcare workers, I think give them the kind of support that they need to cope with, the vitriol that they are sometimes exposed to, and making it clear that not everybody thinks like that.
Absolutely. Well, thank you, Talya, so much for your time. It was very informative. I'm going to let Lisa close this session, and thanks again for everyone for tuning in.
Thank you, Noah, and thank you, Dr. Greene, for your research and insightful remarks. Your dedication to understanding how this pandemic is impacting people we depend on the most for care and guidance is crucial to supporting everyone's well-being. If you have further questions for Dr. Greene, please visit our COVID-19 Resource Center at asuh.org and submit through the form at the bottom of the page. And additionally, if you are inspired by what we've heard here today and would like to support Dr. Greene's current research or any other University of Haifa program, please visit asuh.org/donate. Stay healthy, and we very much look forward to seeing you soon, either online or hopefully here in Haifa very soon. Thank you.